What is going on? Germain Craddock here with another episode of the Dr. Rises podcast. I have a very special guest, Dr. Tammy Nguyen, with me, and we'll be introducing a new mini-series exploring specialties in residency. So for Dr. Nguyen, she's a family medicine resident, PGY-3, and we're going to be talking about family medicine. So what is family medicine? Who's a good fit for family medicine? What kind of residency programs they have for family medicine? And then what kind of fields that you can practice in with family medicine and kind of what career paths you can go, after you finish practicing, and also fellowships. So, Dr. Nguyen, can you go ahead and introduce yourself?
Dang. Okay. Hi, guys. I'm Tammy Nguyen. I am a third year family medicine resident at Medical City Fort Worth. And what else about me? I'm originally from California. I went to UC Davis. I have my, got my degree in marine biology. So we can always talk about that later. Anyway, marine biology. And then I'm a master's in gerontology, went to med school in Las Cruces. So I have my DO as well. And then family medicine. And now I'm here. And what's up next is fellowship in hospice and palliative.
So it's like one of those fellowships that you can do. It's a year long, correct?
It's just 1 year.
Just 1 year.
Bless.
So, yeah, I know what, like internal medicine, a lot of theirs are basically 3 years.
Yeah.
So it's guaranteed 6 if you're doing any kind of thing outside of hospitalist.
Yep. And then there's like subspecialties after that if you just want to just keep going.
Really?
Yeah. So like, let's say cardio. So you do internal medicine for 3 years, and then you do cardio for 3 years. And if you want to do heart failure, that's another 2 years. My gosh.
That sounds like a lot of time.
That is a lot of time. But some people, it's what you want to do.
Fair enough. So kind of breaking ice here with our first question. So how many patients have actually gone to you asking for Ozempic?
Bruh. So not as much now, because I think that they've tried, and then just with like supply and demand, they haven't been able to get it regardless of what we do. And there's also some clinics and stuff like that that do compounding semaglutide, which is Ozempic. But so not as many, but in the beginning it was almost everyone. And it was interesting because it varied how people would ask for it. Some people would straight up be like, hey, I want that Ozempic stuff. And I was like, hey, you don't have diabetes? No, kind of thing. And then other people are like, a little bit like beating around the bush kind of thing. They're like, hey, like I have a family history of diabetes, and like my friend and like TV, like what's that stuff that the celebrities use? I'm like, just ask me. Like I know what you're getting at kind of thing. But it was probably maybe like a quarter of the patients that come through in a day. So if I see like, I don't know, 18 patients, like a quarter of them would ask. But now it's like a little bit less because either they have it.
Got turned down.
Yeah, either they have it or they got turned down.
Fair enough.
And then some people, they like get it from somewhere else. Like I have a patient that got it use their mom's, which we don't recommend. And they're like, I got some bad symptoms. I'm like, yeah, maybe you shouldn't use someone else's medicine. Don't do that.
Oh, wonderful. So kind of bridging back. So for family medicine, so kind of what is the role of a family medicine physician? And then where are they typically practicing medicine?
I think, so the role of family medicine, a lot of it is like you are kind of like the quarterback of the patient's care. You're their first line, pretty much. Like they come to you with anything, big or small, and you take care of it. And if it's beyond you, then you throw it to like a specialist or something like that. I don't know if quarterback is the right metaphor for it, but you know what I'm saying. So it's like we do as much as we can preventative care wise, and then beyond that, it's like you get them to where they need to go. So I think that's like a huge part of healthcare, because you don't necessarily want all of your patients going to the ER and just being taken care of acutely like that. And then what's it called? Your second question.
Where do you practice primarily?
Primarily outpatient, but I think that's like a little bit of a misconception, because I know that a lot of people, they're like, oh, well, like family medicine, I'll use it as like a backup, and then I'll just do outpatient. I think like the biggest pet peeve, the word just, like, is the biggest pet peeve for me. It's like, just do outpatient. I was like, there's a lot of options with family medicine. It's like you do outpatient, inpatient, combination of both. I think it's what's great about the field is that it's so flexible and it's whatever you want it to be.
Yeah, because I know before internal medicine was a thing, hospitalists were all family medicine physicians, so they would do inpatient or outpatient or a combination, because I know some of them do both. So they'll have any of their patients that they get from their inpatient service, they'll, if they want to, they can transfer them over to their outpatient service. They'll kind of do a bit of both. But I think with the rise of internal medicine, that's either taking the place of, or there's less family medicine doctors doing inpatient stuff.
I think that's the hard part too, especially if like your residency training doesn't have as much inpatient, or the acuity in the hospital that you're working at is not as high, then maybe you're not as comfortable doing inpatient medicine and seeing a little bit more complicated stuff. And then you kind of maybe shy away and then do outpatient stuff because you have a little bit more time with outpatient stuff to have things cook.
Yeah. I know with us at JPS, like their family medicine program is very close to an internal medicine program. So like a lot of them are trained more like hospitalists rather than family medicine doctors. So like a lot of them feel very, very comfortable in an inpatient setting. And like you were saying, it just kind of depends on the program and what they have to offer, and, you know, kind of how their services are set up.
Yeah, JPS is like, they run that hospital pretty much. And I was like, more power to you. I was like, good for you.
With family medicine, so we kind of briefly touched on, you know, kind of the fields that you can practice in. So, you know, you're going to palliative care. Kind of what other fields can a family medicine physician practice in?
Whatever you want. It's whatever you want to do. So like family medicine really, like, you know, there's that phrase, it's like from the womb to the tomb or cradle to the grave, pretty much. So anywhere on the spectrum that you want to like specialize in family medicine, you can do. Like you can specialize in, JPS has like the maternal family medicine where you can essentially be like a OB and deliver babies and things like that. So you can specialize in that. There's sports medicine. There's sleep addiction medicine, I think.
Pain medicine.
Pain also. And then hospice palliative. Really, it's just, if you want it, you can seek it out and do it. I think there's some that are like a surgical kind of thing.
Yeah, I think for especially ones that are in more rural settings, like in, you know, you're basically their everything doctor.
Yeah.
And unless they absolutely have to, like you're going to be the one operating on them and potentially doing surgeries with them.
Yeah.
They have, I think, trainings that for family medicine doctors that they get that surgical, like, and again, it's acute and like not, you know, trauma level 1 stuff.
Just like an appendicitis or something. Not just, I mean, an appendicitis
Yes.
kind of thing.
But like stuff that is probably more feasible for a family medicine doctor to take on, you know, in a surgical setting. And I think in the case of, you know, if you live 5 hours away from the closest level 1 trauma center and getting airlifted they're not going to airlift you for an appendicitis.
No. So it's like, we can take care of it here. And the thing is, like, there are some medical students who maybe they don't necessarily match like in the first round, and they don't match into, let's say, surgery or something like that, and they do end up matching into family medicine. There is an opportunity to still do a specialty where it's more hands-on and where they're more procedure-based, and they can be in the OR. It's just probably, like you said, like in a more rural setting. But if that's what you want to do, you can still do it, you know?
Fair enough.
So
Now, how many times have you been asked to diagnose someone that you just met on the spot?
bruh. I don't, like, in the beginning as a med student, I was like, man, when I become a doctor, I'm just going to tell everyone that I'm a doctor, because I'm so, like, you put so much effort into it. You just want to share, like, your accomplishments and stuff. But then, like, after a while, once you say it, then people start asking, like, oh, well, I have a family member who has whatever. It's like, what do you think my chances are getting whatever? Like, I don't get my nails done often. But when I go and they're like, oh, what do you do? I'm like, I'm in healthcare. And they're like, but like, what do you do? And it's like, I'm a doctor. And they're like, oh, well, you know what? My wrist like really hurts. Like, and I don't know why. And I was like, well, girl, you're always doing like this kind of thing. That's why I heard. So you should, yeah. And it's awkward just because you want to help them, but they're not your patient. So it's not like appropriate. But then you don't want to dismiss them either because they'll be like, wow, you think you're better than me. You don't want to help me. And it's like, I do, but I don't know you. It's like, yeah, quite a bit.
No, I can only imagine. With family medicine, so you're talking, we work, more outpatient setting versus the inpatient setting. But our residency programs, do they have some more like academic ones that are like research heavy, ones that are more designed for like rural medicine? Like how are those residency programs actually divided up or like split up and focused?
Yeah, there are. So once you get into like once you start applying for residency, you'll just have a whole list of programs. Definitely recommend making a spreadsheet ahead of time, and you can look on, like AMC, I guess, on like Frida. Yeah. They have like all the information on the different programs and things like that. And just like if it's a community program, if it's an academic program, academic will be associated tightly with or closely with a school. So like I think UT Southwestern is an academic, like Cleveland Clinic is academic, things like that. So they, like you said, they're stronger with research stuff, and then community, like Medical City Fort Worth is a community program, and there's like rural ones also that are like maybe 1 or 2 residents per class. You get to do everything, which is good for them. And I was like, so it's really like what you're looking for, if you want. Typically in academic programs, you see a lot of the weird stuff, like a lot of like the zebra things, because in community settings, sometimes you can work them up to a certain point and then you're like, well, okay, now this is like a zebra and I don't know, we don't have the specialists for that. And then you go to an academic program and then you have someone who's like MD, PhD or something like that studied the specific thing, and then they can help you further.
So the ones with like the Wilms tumors and like the very rare things that you just won't ever see.
Yeah, like Rett. And I was like, bro, what? Like,
I learned about that for step 1, and that was the only time I ever.
I have a patient that I was like, oh, okay. And I was like, well, what do I do now? And I was like, we're gonna refer. It's you see a lot of interesting things.
So with family medicine, like what are you typically doing as far as treating your patients? Like what is kind of your bread and butter that you do for treating patients, like your patient population that you're working with primarily?
That also, I think, depends on like the program and the community that you're serving. It depends on like the socioeconomic like status of the community that you're at is what you'll see and how compliant the patients are. A lot of family medicine will see like the bread and butter, like you're saying, is typical like chronic conditions, diabetes, high blood pressure, things like that, high cholesterol, stuff that you're managing long term, like those kind of chronic condition stuff, like anxiety, depression, like that, you see a lot of that stuff. And then, anything kind of when it gets a little bit more complicated, depending on where you where you train, like how comfortable you are doing it, you can take care of it yourself. If not, you can always refer out. But you don't necessarily want to be like the person that refers out all the time, Yeah, at least that's what I think.
Yeah. I guess like with hypertension, if you can manage it with your medications, if there's certain things like the diabetes, I mean, you can always consult with like pharmacy and pharmacotherapy if you need to like make adjustments that are like, okay, like I've tried everything. Then
it's like help. Yeah. I have no, like in our clinic at TCOM or like at UNT HSC, it's like we're great. It's great that we have pharmacy there, because at some point I was like, I know the medications, but sometimes maybe there's something I'm missing, and you can refer over to pharmacy and they're like, oh, this is a better regimen, and you're like, oh, great. Yeah. And I know not all programs have that, so I think that's like an awesome addition. And now we have like behavioral health too. So you can, if someone's having a crisis, you can be like, oh, here. Oh my gosh.
Yeah. No, I mean, I think that's where the beauty of it is like knowing where your limits are and then knowing where your capacity is, like you can figure out where that line is. And sometimes it's a little bit more black and white, sometimes it's a little bit more gray. But, you know, obviously, because you are, I think, front line for so much of these things, if those patients aren't getting to the right people, then they're never going to get there.
Yeah. And it's just hard because it's like, there's only so far you can take people sometimes. Like, you can lead a horse to water, but you can't, like, make them drink. You hope for the best. You're like, hey, here's what we can do. But if they don't do it, you're like...
Yeah. No, I think that's a big case with type 2 diabetes. I think it's a big one where a lot of the onus lies on the patient, like, you know, dietary modifications, lifestyle modifications, and, you know, depending on the person that you're working with, either like, oh, well, I'm taking my semaglutide, I'm taking my metformin, I'm taking my insulin, whatever. And they think they're okay and they don't need to make the lifestyle adjustments because they have the medication that they're on.
It's a lot of negotiation. I guess family medicine, if you're not into like having that conversation and like negotiating with like your patients and being their homie, I guess, because that's really like how I typically like to practice. And I was like, hey, like, yeah, I'm your doctor, but let's level and we're in this together kind of thing. Let's make this decision together, or like what's going to work for you. But knowing that it's not all on me, like there's stuff that you have to do too. And I don't remember when we were working together if we ever saw, I'm sure we saw a patient with diabetes, but I always talk about, especially with the diabetes patients, like the Illuminati of diabetes. And I was like, and they're like, what are we talking about? And I was like, it's diet, exercise, and medications. And it's like, I only control one, like you're in charge of the other two. And then we'll see like how it goes from there, you know? So.
No, I remember with, so before medical school, I had like my own personal training business, and, you know, I would train my clients. I'm like, look, I'm only with you 1 hour a week, or, you know, this amount of time. We're doing twice a week training. Like, I can help you with your diet, but you have to be the one that puts the food in your mouth. I can help you with your exercising, but like, I need you to work out outside of just the times that you're with me. Like, there's a lot of onus that falls on you. And this relationship that we have isn't going to be successful unless you pull your own weight.
Yeah. And there's like, it's hard because you want to tell them that just like straight up, but not everyone responds the same way. So you have to like adjust the way you say things, and, you know, body language, like, oh, they're not vibing. We're not vibing. Or like, they're not, okay, this is not working, you know? So then you're like, okay, how am I going to change this so it clicks with them, you know? Or like, what can I do? Like, what plan can I come up with that is manageable for them? How do I motivate this patient to do anything, you know? So yeah, that's a great, it's a hard part of it, but you know, you figure it out. Okay.
So word on the street is you love boba.
Dude, I had boba like 2 days ago. I had it yesterday, actually.
Oh yeah? What's your favorite flavor?
Anything with ube and anything with like, so like the milk tea stuff, ube, jasmine tea, action. And then if it's just like tea stuff, because they're different, like anything passion fruit kind of flavored. It's good. I was thinking about that question too. And I was like, if he asked me what I would order, I'd be like, oh, I don't know. And I'm like, I don't know. I just go there and I look at the menu. I'm like, that sounds good. I just recently went to this boba shop up in Plano, and like usually the places don't put the calories of the drinks.
That's rude.
They put the calories, and I was like, oh, no.
It's like ignorance is bliss.
Yeah, that was a whole meal. Like the calories was a whole, like, okay. I already had a whole meal. It's fine.
So I know we talked briefly about, you know, you can from birth to the grave as far as treatment for a family medicine doctor. So for someone that's, you know, maybe considering pediatrics versus internal medicine versus family medicine, kind of what are the big differences that you would say kind of would lead someone to one versus the other?
Yeah. So I think a big part of like seeing where you want to go is your med school rotations, really. Like when you go on your pediatrics rotation or IM or family medicine, it's like, do you vibe with these people? Do you like the lifestyle that the specialist is living right now? It's like, do you like this patient population? Like, do you like seeing kids all day, like in an outpatient setting, or do you like seeing kids all day in an inpatient setting? Do you like having to manage like parents' expectations and that kind of stuff? Like, that's hard for me because the kid is my patient, but then I have to deal with like someone else. And I don't have kids myself, so it's hard for me to connect. And I think like that connection is a big way of motivating patients and their families to do anything, you know? And then internal medicine, it's like, okay, all adults. I could do that. I did dual apply. So that's why I was like, internal medicine, like I like adults. And at that time I was like, when I was applying to residencies, it's like, do I like inpatient or do I like outpatient? Because I was very narrow-minded and like family medicine is only inpatient. I mean, only outpatient. But, you know, over time I'm like, oh, well, I could have done internal medicine. Okay, anyway. But it's like, do you like more high acuity in a inpatient setting? Do you want to just work with adults? And then family medicine, are you just like, you want to see everything? Or you don't mind seeing like kids, older adults, like everyone kind of thing. It's really, what do you want your future practice to look like? Who do you want to interact the most with? It's like, if you don't want to interact with kids, like at all, internal medicine. You know, it's like, if you don't mind kids, family. You know, if you don't want to deal with adults, like taking care of adults, then peds kind of thing. So see who you vibe with. For sure.
So then who do you think is kind of a good fit? Like who kind of falls under the box of someone who would be a good fit for family medicine?
I was thinking about that a lot too. And I was like, oh my gosh, what makes a good family? Like, what is a good personality? I think it's someone who enjoys everything because you will experience everything. Like you're just like, dude, I just like everything. I don't know, kind of thing. There's not one thing that calls out to you. It's like you like that, just like everything. And then you like to be part of the family, essentially, if you're kind of nosy and you want to be like in people's business. You know, family medicine is great for that because you do get really good continuity of care, especially in like our program. Like we follow them in clinic or follow patients in clinic, and then sometimes if they go to the hospital, we follow them in the hospital too. So you're just always there and you're a part of their life for like at least 3 years in residency. So I can't even imagine like, you know, as an attending that you're just following families, like these kids from when they're small until they're adults.
And I remember one of my preceptors at HSC, he would have the mother and the father, then you'd have the kids, then you'd have the abuelitas, and like you have everyone, like literally he was the doctor for everyone in that family. So like he was their one doctor. And so he's just getting a little bit of everything and, you know, managing obviously, you know, their chronic diseases or, you know, just doing like checkups for the kids, you know, the yearly checkups and well child visits. And that was his practice. So many of them were just like family, just like groups.
Yep. It's just like being part of their family, because you're going to be calling them with their labs, like following up on them on stuff. When you see them again, you're like, hey, like you said that you applied for whatever, like what happened with that? Really like being so integrated in their lives and stuff, you know, because you get continuity in an inpatient setting too if patients come in kind of frequently. So you get, because I was talking to my friend, one of my best friends who's IM, and she's like, well, I get continuity also in like a hospital setting because I see the same people sometimes. And I was like, yeah, but this is a little different because it's not always the same issue typically. It's like you get to see them grow and all that stuff. So it's really like how involved. And some people are like, I don't want family medicine. I don't want that continuity. I just want to see them and just be like, peace, you know? So
with your family medicine residency, so you're wrapping up your 3rd year, you're getting ready for your fellowship. What is residency like for a family medicine physician?
It's a little bit like med school clinicals on steroids. Like, because you do all the rotations again, right? We do family medicine, like clinic, and we do like IM surgery, like, and all the different specialties that y'all do in medical school. But then now you're the physician, you know, so you're making decisions and things like that. So I think so it's a little bit like that. So it's a lot of the med students that I work with in clinic, I say like the biggest transition from 4th year to PGY-1 is all of a sudden you're making decisions. So it's steep in that sense because you're like, oh, as a med student, whoever you're with, they're like, okay, what do you think? And then it's like, okay, here's what I think. But then ultimately it's whatever they end up doing. But then now it's you. It's you. Oh my God. Now it's like, okay, this is what I think it is. And like, how do I work this up? I need to put these orders in. What are the next steps? Like, when do I follow up with this person again? What do I prescribe? What am I looking for? If I don't find that, then what kind of thing? So it's just med school on.
So then what kind of services do you do as part of your residency?
Like rotations?
Yeah.
Okay. So we do like cradle to the grave, like newborn. So when babies are born, we go do their newborn exam and stuff like that. Pediatrics, like outpatient pediatrics, inpatient pediatrics, IM family medicine, sports medicine, ortho, gen surge, cardio, nephro, pulm, all the things.
It's a little bit of everything.
Bro, all the things. It's a buffet.
Yeah.
It's a buffet of medicine.
So between a patient with hypertension and a patient with diabetes, who would you rather treat?
How compliant are they?
Let's say not compliant.
I think I might say diabetes. Because I was thinking about this and I was like, I was going to choose hypertension. But then I think I've had some pretty good success with diabetes patients, regardless of compliance, because I feel like I found like a spiel kind of thing to talk to them about. And I was like, okay, like we were talking about the Illuminati of diabetes, and then just like lifestyle changes, because it's hard. I get it. You know, I'm surprised I don't have diabetes myself, you know, but it's like, I think it's just like the incremental changes that you can offer a patient with diabetes and be like, hey, okay, this is what we're going to do. And these are the changes you're going to see. Hopefully, if you're compliant, and if you're not, then this is what you're going to see. And then I kind of told you so, but in like a subtle way. So I think I've managed a lot of diabetes patients, and I think I could do that. I'd rather do that now.
I feel like with diabetes, there's some more like concrete things that you can like land on, you know, like amputations and like peripheral vascular disease and all these that, like, and changes in your vision. Whereas like hypertension is still a little bit like,
You're going to have a stroke.
Yeah.
I know. You're like, is your vision blurry? And they're like, sometimes. I'm like, see, that's your hypertension. But it might not be, you know, like diabetes, there's patient, like you're saying, they say like, oh, my feet are kind of tingly. I'm like, this is the beginning.
Yeah.
There was an article not recently, but there was an article that was like, how do you motivate patients? Like, does fear motivate patients? And fear does not. So I try not to scare patients into doing things instead of motivating, like, and educating. I think a lot of family medicine is like education, you know, so it's a lot of like, this is what diabetes is. This is what's going on. Even if it's over their head, you just keep saying it. And like, this is what your changes are going to do. This is what this medication does. Because I think like a large part of having a patient be compliant is having them take ownership of their health and ownership of like what's going on. And if they don't know what's going on, then how are they going to? They're like, oh, I'm just doing it because my doctor told me to.
Yeah.
So.
Yeah. Or like patients that, you know, have these disease states and they don't quite understand what they are, but like, oh, I have this. It's like, okay, well, what is that?
What is
like, I don't know. My
You're
doctor
like,
told me I have it.
Yeah. So I was like, I was going to give an example. I'm not trying to throw anyone under the bus. I'm going to be kind of like vague. There's somebody, I know no one that I like work with, but a patient was just recently diagnosed with like diabetes and hyperlipidemia. And then the physician just prescribed, first line medication, no follow-up labs or anything like that, no explanation. And then that patient comes to me and they're like, what does this mean? And I was like, shouldn't your PCP talk to you about this kind of thing? So then I looked over the labs and I told the person, I was like, yo, you straight up have diabetes. And they're like, I wasn't told this. I was just told to take this medicine. I'm like, what? But then now the patient's like, okay, I know what it is. I know what I'm looking for. Like, I'm going to make these changes. I'm like, cool. You do that, but it's a lot of education.
Yeah. Mm-hmm. I feel like the other thing with that education aspect of it is because everyone's a little differently. Mm-hmm. You teach people slightly differently. You turn your spiel around a little differently. You change the way you're motivating people differently. And so I feel like with family medicine, like you're never doing the same thing for each individual person. It's very much so like, yeah, you may be prescribing the exact same medication. You may be doing the same like mode of, treatment and pharmacotherapy, but everybody does it slightly differently. Everybody is motivated slightly differently. Everybody's gonna be like, okay, well, like I'm actually taking the onus on it, or I have this family member that's like going to help me through this, or like understand it. Like I feel like you have to get good at knowing those triggers for people.
It's being like flexible and like personable in the sense like you can social cues, like situational awareness, because I think some people don't have that unfortunately, and then they treat medicine very like algorithmic and like, okay, I see this flow chart and up to date, this patient's like fasting blood glucose is whatever, because of that they have diabetes, I'm going to do this, I'm going to do this, I'm going to do this, I'm this. I mean, it's like, okay, sure, yeah, like you do that, but like how are you going to talk to them about it? How are you going to explain this? So it has like, are they picking up what you're putting down? So it's like, I've had patients where they're like, I'm not really sure why I'm taking metformin. Like, what does it do? And I'm like, okay. I'm like, metformin, so your body has receptors? And I'm like, so the receptors are like this? And then it's not like, just doing what you can to like explain stuff.
Or like if a patient absolutely hates needles and you're saying, go take insulin, or say, we're going to do a shot once a month for however long because we're taking semaglutide.
Like,
it's like, I hate needles. Like I can't even get my blood drawn. That kind of stuff. Like, okay, knowing where those patients and those options are. It's like, okay, well, we have pills, we have this. And I think that's where you're kind of tailoring everything to those patients.
It's the art of medicine. Duh.
So for either first year, second year, or, rising third year medical student that's actually interested in family medicine, that kind of earlier on in the medical career, kind of what do you recommend that they kind of do to kind of help set themselves up so they can be successful in pursuing a actual family medicine residency?
Do it. Like, rotate and see what it's like to be a family medicine physician. It's like, do the audition rotations, like pick it as an elective if that's what you want to do, like experience it to see if the field actually matches your expectation, and do it in different settings, not in like the same like clinic that is like a family friend kind of thing. It's like, go to different places, go to like the urban clinic, go to like a rural clinic, go to different places, different settings, meet different people, see different cases kind of thing. It's like, is this what you want to do? Is this like, so you have different experiences. I think I talked to you about this, about like in medical school, I'll have a list of like interesting patients and interesting cases that you've had, because once you start interviewing, then you can speak to them. Because usually one of the questions is always like, oh, what is like an interesting patient that you were involved with their care or something like that. And you'd be like, oh, there was this patient with hypothyroid and then it didn't look like it, or something like that, whatever. You just want to have like a variety of experiences so you can see if this is what you want to do or not. And then kind of like go from there.
So then you talked on like audition rotations. How would you kind of divvy those up, and where would you focus your attention for audition rotations?
I think, let's say, so audition rotations can be kind of like a double-edged sword a little bit, because it's like if you're at the audition and you do fantastic, you love them, they love you, you kind of move up in their like mental rank list or like real rank list kind of thing, and they move up on yours. But also at the same time, if you're doing audition rotation, you love them, they don't love you, or you don't really like them, you feel like you wasted your time. But then it's, at the end of the day, it's probably a good thing, because then you're like, well, I don't like the culture. It's like everything about this program on paper sounds great, but then being here and auditioning, I don't like the culture. I'm not like, I don't vibe with the residents or my possible future co-residents. Then they move down your rank list, or maybe you don't apply, or maybe you don't rank them or something like that. But if you love them, they don't love you, like that kind of sucks too, because you're like, oh, I love them, I love the culture, I love everything, but they're like, oh, this person's like weird, I don't like them, so
Yeah.
so that's a hard question. Like, how do you strategize like doing audition rotations with family medicine? For me, I just think it's just go for it. Like, whatever program you feel you're like, damn, this program, it's gonna be my number one no matter what. Go do an audition. See if it actually is what you think it's gonna be, And if it's not, great, you figure that out. And if it is, great, you figure that out too.
I think, even though I'm not applying family medicine, me going through the process of applying for audition rotations and going through this whole process of figuring out where I'm, ideally going to spend, for me, doing 6 audition rotations, so 6 months of auditions. It's going to be the case of one thing I found is kind of similar between each programs. Their websites are very much so like kind of cookie cutter, because obviously they're only allowed to put so much about their program on there, and you can only find out so much without talking to either a resident that's been a part of the program or talking to the program director or knowing someone that's been there. And I think it's one of those where spending a month at that site, spending a month in that rotation, in that field, there's no real substitute for it, because like you were saying, if you find out like, okay, on paper, this program sounds amazing, it's everything I want, it's in the city I want to be in, but then it's going to be 3 years and you're going to be miserable. Where, with family medicine, you have flexibility. Like you can be in different places, you can choose different programs. And if you're looking for something different and that program doesn't offer that, then that's probably not a good fit for you.
And what's great about like the interview process and all of like fourth year, which I think I'm telling you, fourth year is the best. And I was like, fourth year is great. Like you're interviewing at the program, and you're also interviewing the program, if that makes sense. Like you're interviewing them as much as they're interviewing you, so it's being on both sides of it, like being like interviewing for residency and then being a resident and being part of the interview process. I see both sides. I'm like, oh dang, it's like dating. So you're like, oh, I like you, do you like me? But we can't talk about it because it's an ACGME violation kind of thing. So like really keep that in mind. Like I feel not a lot of med students, but occasionally med students, they're just like, oh, like I really need this spot, like I really want this, like I need to just like conform myself to their culture. But really it's like, be yourself, because you don't want to fake it like the whole time you're there. You want to be yourself and be accepted for who you are.
I think with an interview, it's one day, you can put on a face, but I feel like for people that do an audition, you can't really fake it for a month.
Yeah,
Most people break. I think most people break. And so I think it's knowing how much of yourself to show, because obviously, you want to be yourself, but like, if you curse like a sailor and there's attendings that like really aren't like, into that, and they're like really, it's going to kind of turn them off, then, maybe hold it back a little bit.
Yeah. It's like dating.
Yeah. It's like knowing how much of yourself to show. Like you want to still be personable. You want to still be, someone that they can get along with. I think for me, one of the biggest things that I've heard is like, you want to be someone that these people want to grab a beer with at the end of a workday. 100%. Because if not, then it's going to be a long, for orthopedics, that's what I'm interested in applying, it's to be a long 5 years.
100%. Even like, I think any residency, a lot of times, like they ask you like the usual questions, like why this specialty, like why our program. So those are a couple things to like keep in mind during the interview process. And then at the end of the day, it's like, do you vibe with these people? Like during the like when we're interviewing, I tell a lot of our candidates that, and I was like, you know what, just when you're on the trail, it's like, do you vibe with these people at this program? If you don't vibe with us, that's just how it is. Like, and if you do, great. And when I was interviewing, a big part of me choosing this like Medical City Fort Worth as my like program is when we had our social. It was like COVID-y time, so ours was through Zoom, but the interactions that I had with the current residents at the time and like the chief, Dr. Westbrook, it was just like, dang, like I want to be your friend. You know, it's like you may not still be around, but then if the other residents are anything like you and I get to like work with people like you, I want to be there. Like I want to hang out with you kind of thing. So, you know, that's a part of it also.
I think it's a very understated emphasis when you're rotating is that unknown. It's like that qualitative measure that just like, okay, this is a good fit. And I think it's like you can't put like a checklist of all these things are working for us. Like it's like you know or you don't. And ideally, you have enough self-awareness to know.
You'd hope so. You would hope so. There are times like it's like, yeah, you know, tone it down. Don't curse like a sailor when you're on your rotations and things like that. But also operate and be the person that you would be if you were one of their colleagues in the future. Because there are some times when you said it is hard for people to fake it for a month. I've seen people kind of like be different before, and you're like, oh yeah, they're great. But toward the end of like at like week 4, you're like, something popped out that was kind of, and then come residency time, you're like, oh no.
And at that point, it's a little too late.
It's too late. We're like, okay. But, you know, you work with it.
Yeah. So, would you rather have a patient that Googles everything or a patient that is consistently late?
I hate the lateness thing. I would rather have someone that Googles stuff because at least we can Google it together, because I do like to Google things with my patients together so we can like see where is this coming from? You know, like what source did you find this on? Like, let's talk about this. I was like, this is my knowledge base of whatever you're Googling. So let's look up like an article. Let's look up something on like ACOG. Let's look up something on like American Heart Association or something like that. Kind of like it's an opportunity. There's always like a learning opportunity in family medicine with your patients. It's like, okay, come at me, like Google. Like you can get defensive because I do that with my parents for sure. Like when they're like, well, Google said, I'm like, where did Google go to med school? And my mom's like, ugh. And I'm like, yeah, that's right. But I don't do that with my patients. I don't say that. I'm just like, okay, let's look it up. Like show me what you looked up. And then we go through it together. I'm like, you know, this is like a .net. This is someone's blog. You know, it's like, who is this person kind of thing? Where is this coming from? It's like, can I show you how I would look this up? You know, it's like, if I'm looking this up, yeah, sure, I'll Google whatever. And it's like, but let's look at like the sources and stuff like that. So they kind of moving forward have an idea of how to search things themselves that are a little bit more credible. Then we'll talk about it, you know.
Fair enough. So kind of wrapping up, do you have any other parting words of wisdom for someone interested in family medicine?
Dude, just be yourself. Like, I think being transparent and being yourself is a huge part of family medicine. I feel like that's why I have a pretty good rapport with the patients that I have. It's just that you're human and it's okay to be human. Once you get that like DO or like MD behind your name, it's like, sure, like you know stuff, but you don't know everything. It's like, it doesn't make you better than anyone. You know what I mean? So it's just like, sure, you know stuff, but collaborate with your patients. Remember that you're human, they're human. We're all trying to like learn stuff. So like family medicine is like learning it together. So it's all good. Just be you, you know?
All right. Well, thank you very much, Dr. Nguyen. Thank you so much for tuning in. I'll go ahead and make sure I link Dr. Nguyen's socials in the bio down below. If you like this video, go please like or subscribe, and I will see you in the next one. A bientôt.